So this session is about health technology assessments, why, how, so what. Maybe the heading isn't exciting, but let me tell you why, and probably most of you already know why you're here. I mean, there are an enormous number of drugs and therapies coming to the market. For those of us that live with hemophilia, practice in the field, or make products for the field, we know that we are an expensive disease. And so as governments come under increasing health pressures to begin to figure out how are we going to pay for it, and what is it we're going to pay for, what's the next drug that's going to be approved, we really want to take some time to understand what, in fact, is the process by which governments make those decisions, what can we be doing now to prepare for it. And so we've prepared a little bit of a different kind of session today. In lieu of having sort of two didactic lectures that just walk you through a long series of talks and getting at the end and taking a few questions, we've actually planned what we hope will be a little more interesting is an interactive session. So these guys are going to get up and down and work together to tell you the story of how HTAs work in the or health technology assessment works in the United States and how it works in Europe, and then also a little bit about how it works around the world. So that's about a half hour of presentation. So stick with us through that, because I think that that's an important level set for us to really move into what I hope will be a more interesting and interactive discussion. So this is a 90-minute session, and we've really planned an enormous amount of question and answer time. I have a few questions, but please be thinking about them both in relation to the process of health technology assessment and how we assign value, but also in terms of what you might wonder about what's on the horizon, and is anybody going to pay for it? Is it great that they just made it, and am I going to have access to it? So we have two, and I really don't use this lightly, we have two really sort of world-renowned experts in the field for us. So I'm really pleased with the folks that we were able to recruit to come and present to us today. The first is a guy by the name of Cliff Goodman, to my immediate right. Cliff is the Senior Vice President of the Lewin Group, which is a health policy consulting firm, and he has enormous global expertise in health technology assessments. Previously, he has been the chair of the Medicare Evaluation, Development, and Coverage Committee for the U.S. Centers for Medicare and Medicaid Services. After that, he actually served as chair of the Health Technology Assessment International Organization, working in the field internationally. He has been working with the hemophilia space some. These guys are not here as hemophilia experts, but they both have some degree of familiarity with our space. So we're really pleased to have Cliff presenting both the U.S. As well as his global perspective. To sort of round out the program, equally impressive, we have Chris Henschel. So Chris is the director of a science and engineering-based group in the Office of Science and Technology in London, where he is responsible for research and innovation. Chris actually served as, I believe, the inaugural chair of HTA International, so the Health Technology Assessment International. Most recently has served as chair of the Health Technology International's Policy Forum, and he has a very good grasp of how HTAs work in Europe, having been in that environment for several decades. So between the two of them, we're hoping that they can give us a nice perspective, and what we're going to draw out in the end are some of the differences between what's happening in countries like the U.S., what's happening in Europe, and then what might be happening in the rest of the world as they move in this direction. So I'm actually not quite sure which one's coming to the podium first, so please welcome Chris. Oh, no, Cliff. Cliff. I'm sorry.
I'm Cliff. He's Chris. Thank you very much, Mark Skinner. It's a pleasure for us both to be here. If you know something about HTA, you know why you're in this room right now. If you don't know anything about HTA, it's a good thing you're in this room right now. If you care at all about access to hemophilia care, from factor to hemophilia treatment centers, you need to understand, try to figure out, gain some intelligence on what is the role of health technology assessment, how does it influence payment decisions, sometimes clinical decisions, sometimes how much you have to pay out of pocket for various products and services. In every one of your countries, there is at least one, but sometimes many more, pieces to this puzzle about who influences whom in the special role of HTA. This is increasingly important. If you don't know about HTA in the years coming forward, or someone who works with you doesn't know about it, your ability to access care may be affected. These are my disclosures. And I won't read them all to you, but I've done some work in the field and am part of ultimately a very big healthcare organization. I'm going to switch back now to Chris Henschel, who'll give you his disclosures and start our program. Chris.
Thanks, Cliff. So these are my disclosures. I don't think there's anything relevant that constitutes a conflict. If anyone wants to ask me about them at any point, they're very welcome to. The talk today, Cliff and I are going to try and cover these topics. Basically, we're going to start by a few words about what we mean by value, value for money, affordability, and why they matter in healthcare. We're going to go on then to explain what health technology assessment is and how it seeks to assess value. We're going to talk about how it's used around the world, initially outside the USA, and then we're going to move to look how it's operating in the USA. And we're going to finish this part of the talk by looking at how it's used in some particular situations, high-cost treatments and treatments for rare conditions. That's, as it were, the background, and then we're going to enter the Q&A, which Mark will lead on. So what does all this mean for haemophilia? Okay, so when we talk about health technology, there's going to be a lot of discussion about value, value for money, affordability. So I think it's helpful just to say a few words about what we mean by these concepts. So value refers to the benefit that something offers or brings us. An assessment of value depends on how much we want the benefits that the thing brings. And assessment of value will therefore differ between individuals and groups of individuals. So it's easy to think about these things, I think. It's something very common like a car or an automobile, as you would say in this country. In the case of a car, I say car, sorry, we may value performance, we may value comfort, we may value environmental impact and other factors, and we may value them differently. So different people will value the same car differently. Value is in the eye of the beholder. What do we mean by value for money? Value for money is the ratio between the value that something brings and what it costs us. Very simple. A car may cost more, but it could still be better value for money than a cheaper model because it could provide substantially more of what we value for a relatively modest extra price. So just like views on value will vary according to who you are, views on value for money will also vary according to what we value and our willingness to pay for what we value. Some of us have got more money to pay for things than others. That brings us on to affordability. Affordability is, in simple language, our ability or our willingness to pay for something. So thinking of our car again, we may value an expensive car. We may even think that it offers value for money. But the price may just be too high for our budget. We may not have the money, or we may wish to keep the money to spend on things that we value more. So we may decide that the more expensive car is unaffordable, and we may buy a cheaper model, even though we could consider the more expensive car represents value for money. Okay, so why do all these things matter in relation to healthcare? Surely you may be saying the choice of drugs in many countries, like the US and Europe, is driven by the views of patients and clinicians on the relative value of available drugs. Cost, value for money, affordability, these are concepts that really aren't considered. The system is there to pay for what we want. And that is traditionally what has happened. But in recent years, health systems, insurers, governments have started to consider value for money and affordability in healthcare. This is driven by concerns that the number of healthcare opportunities, the things we can do in healthcare, the demand for those things, and the costs of those things are increasing faster than the funds that we have available. So we're being forced to start thinking about value for money and affordability. Many health systems around the world now make formal assessments of value and value for money to inform their decisions on access to and co-payments for new treatments. And these systems are versions of what we refer to as health technology assessment, seeking to assess value. So, at this point, Cliff is on my heels.
Thank you, Chris. Well, let's talk a bit about what is HTA and how does it assess value. First of all, what is health technology assessment? This is a composite definition that I put together over the years. And keep in mind as you read this and our other information, how this is going to bounce off or reflect on hemophilia care. First of all, HTA involves some sort of systematic evaluation of various properties, effects, or other impacts of health technology. By the way, health technology can be drugs, biologics, devices, equipment, even how we organize and deliver care. In the broad sense of technology, all of those are technology, all of them. The main purpose of HTA is to inform policymaking. HTA is not the same as the policy, but HTA often informs the policy. Next, it may address direct and intended consequences of technologies as well as the indirect, unintended consequences of technologies. There are many things that we use in healthcare that may serve the purpose for which they were intended, but they have other effects. Some of them aren't really the things we had in mind. Many instances of those in drugs, devices, and procedures. HTA is conducted by interdisciplinary groups. HTA is not conducted by just doctors, by just economists, by just epidemiologists. We need all of these disciplines in working together to do HTA appropriately. And HTA uses various explicit analytical frameworks. We just don't wing it all the time or make it up. There's a prospective setup or a plan of how we're going to conduct HTA. And when I say what are the things that are assessed, here are 5 main categories of what which HTA inquires. Technical properties. If it's radiology, it might be how distinct the pictures are. If it's a drug, it might be pharmacodynamics or pharmacokinetics, these sorts of technical things. Safety is a measure of how willing we are to accept risk and adverse events. Efficacy and effectiveness are nearly but not synonymous. They both refer to how well something does what you wanted it to do. By the way, key difference between efficacy and effectiveness is this. Efficacy says, how well does this thing work under ideal circumstances? At the best treatment center, under the best supervision. What's the success rate there? Effectiveness says, well, isn't that great that you've got good efficacy, but how well does it work in the community setting? There is often a difference between these two, and believe me, payers, other decision makers, and policymakers ask that question. How well does it work in community circumstances? Cost and other economic attributes, cost-benefit, cost minimization analysis, cost-consequence analysis, the whole raft of economic studies that are used in HTA. And then finally, social, legal, ethical, or political impacts. You've got plenty of those in your field. You're now starting to talk about genetic therapies and maybe someday gene editing here. Well, you may be good at snipping genes at some point, but anytime we start messing with the human genome, we get certain social, ethical, legal impacts about which we need to consider. And by the way, some of those may be unintended. So these are all under the rubric of HTA. Well, how is HTA used? Remember I said it informs policies or decisions? Well, a bunch of ways. One, and probably the most important these days, but not the only, is to advise payers. They may be national health authorities, health plans, about whether to pay and how much to pay and under what circumstances to pay. That's a big point of leverage for HTA. Payers increasingly seek information from HTA and advisories from HTA to make their very important decisions affecting access. HTA information can also be used to help clinicians and patients about whether to use something or not, sometimes to help support evidence-based clinical practice guidelines. It's to help managers of hospitals, healthcare networks, or even clinics about what sorts of equipment, supplies they should use, or how they might run their facilities. Furthermore, it can even support decisions by national and regional public health authorities, a country that's considering something about clean water can be informed by HTA, about mosquito control, about immunization programs. Now, there's some other uses for it. Sometimes, actually, HTA is used by companies themselves, drug and device companies, to think about, should we go down this route with this new product or not? Or should we stop it? Or should we redirect it? They do their own form of HTA. And frankly, HTA is used sometimes by investors. Those who are thinking about investing in companies that might have a new biologic or a drug for a treatment. And it even is used to inform research agencies about evidence gaps or unmet needs so that they can build research agendas. So, HTA can be used to inform all of these kinds of policies and decisions. Perhaps the one most relevant to you right now is the payer one, but as you can see, HTA can affect other decision makers in your realm that may affect development of new products and access to them. Now, back to what is value in healthcare. Well, as Chris said, HTA seeks to assess value, and what I'll tell you is that looking at value or value for money, it's some function or some combination of the impacts I talked about before. For example, we might have a value function that asks, what is the effectiveness or benefits of something? What's its safety or lack of harms? And what's its cost? So a value function might embrace, for example, effectiveness, safety, and cost. A basic definition, one of them, and this is used for value for money, is basically this. Health outcomes achieved per dollar or other monetary unit spent. Health outcomes per unit of money spent. That is value for money. Some very interesting concepts for assessing value. First, those of us that look at the field say, you know what? It's not just the particular drug itself. For example, we need to consider the costs and the benefits and the harms of the technology itself and parallel or subsequent downstream costs, benefits, and harms. It's not just that drug itself. Is that drug replacing something else? Is the use of this factor going to diminish joint bleeds and hospitalizations in the future? In the long run, will the use of these factor products, or perhaps how we apply them or use them, going to affect the employment status or the health-related quality of life of patients years hence? That's taking into account the bigger picture for value. Now, when we determine value, it can look different ways. For example, it can simply be a side-by-side presentation of here are the benefits, here are the harms, and here are the costs. Just kind of laying those out without doing a calculation. Or sometimes we put them into a distinct calculation and we come up with something like what we call an incremental cost effectiveness ratio, such as, well, when we use this factor product, it costs $100,000 to achieve one more quality adjusted life year. And somebody might say, to achieve one more quality adjusted life year, we got to spend $100,000 out of the budget? I'm not so sure it's worth it. There's an opportunity cost. Maybe we should be spending some money somewhere else. Well, that's part of value determination and also why you want to be thinking that you're aware of this. Now, when we talk about value, when Chris and I talk about it, value depends on the perspective that you're taking. Whose perspective now? You know, we talked about benefits and harms and costs and so forth. Well, to whom? To the patients? Yes, benefits and harms and costs accrue a certain way to patients, but then there are caregivers and families that experience it a little bit differently, providers, clinicians, and others. The payer certainly gets a stream of costs and benefits, and whether they're a national, regional, or a health insurance company. Society at large, in theory, tracks all of the harms, benefits, and costs, or other. So point being that no single value determination works for everyone. Always ask, oh, you're talking about value of hemophilia care? Well, who's defining value, and how are they assessing it? Back to Chris.
So that's a very brief overview of what HTA is and what it's trying to do. We're going to turn now just to give you a little bit of a feel for how HTA is actually operating around the world. So that was the theory. What systems are currently set up around the world? So to understand the non-US perspective, we just need to remind ourselves or look at the way in which healthcare is funded in countries outside the US. So outside the US, governments in many countries play a major role in the funding and sometimes even the provision of healthcare. Some countries, like my own country, the United Kingdom, have what is called a national health service. These kinds of systems have a fixed budget set by the government, often raised from general taxation. But the key point about them is they generally operate with fixed budgets. Other countries, like for example France and Germany, have a more insurance-based system where there is still a very strong role for the government in regulating that market and setting norms and standards, but it is still nonetheless an insurance-based system, and often the concept of a fixed budget isn't how they work. The budget is more flexible. That's relevant, as you'll see, to the kinds of systems they operate. So how do decisions get made in these kinds of countries and healthcare systems? Well, still, whatever the system is, the vast majority of decisions about treatments are typically made at the patient-doctor level. Patients and doctors decide what treatment is best. But they are constrained by a number of things. They may be constrained by decisions at the hospital level about what the clinician is allowed to offer or provide. And there may be national or regional authorities which further define what may or may not be provided or reimbursed. So in many countries, decisions on what drugs may be provided or reimbursed in the public system and at what price or copay are made by a national or sometimes also a regional authority. These authorities making these decisions are typically advised by some kind of HTA body, responsible for analysing the benefits, costs, cost effectiveness, budget impact, all of those facts. And the decision-making authority reaches its decisions based on the reports from the HTA agency and in the light of the resources available and other factors, such as a government's stated priorities. So, for example, a government may say it has a priority for improving the care of cancer patients. So that will be taken into account when someone's deciding whether or not to fund a new cancer drug. So, how do these HTA bodies actually work? What do they look at? Well, they look at the benefit or the value that a treatment offers compared to the existing treatment, that is the incremental benefit, and they look at the incremental price or costs and think what price or cost would be justified. So does the extra benefit this new drug brings, does it justify the extra cost? That is the question they're trying to answer. Now, when they're assessing benefit or value, all of these HTA bodies behave in different ways, but they all have one thing in common. They all put patient survival and quality of life at the core of their assessment of value. They all start from that. That's the fundamental quality that they look at. But then they differ in what else they put into the value equation. So some of them may include wider benefits. They may put in benefits, they may look at benefits to carers, caregivers. They may look at benefits to society more widely. Are there benefits to the economy from having people more in employment? Depending on which country and which system you're in and which HTA agency you're dealing with, they will put different things into the value equation in addition to that basic element of patient survival and quality of life. And moreover, these bodies use different approaches to assess value for money or the most appropriate price or cost. And these two systems fall into two broad systems. Their approaches fall into two broad systems. What are called clinical added benefit approaches and what are called QALY systems. Now let me start with the QALY systems. Cliff has already mentioned quality adjusted life years, or QALYs. So systems using QALYs look at the length of life following treatment and at the quality of that life, and from that they make a very simple calculation of quality adjusted life years. So if you live for 10 years after taking your drug, and those 10 years are all healthy life, you gain 10 quality adjusted life years following the drug. If you live for 10 years but are suffering considerable pain or disability, then you will have less than 10 quality adjusted life years. They will be adjusted down because of the reduced quality. So you may have only 6 or 7 or 8, depending on the level of pain or disability or experience. The difference between the QALYs you get with the new treatment and the QALYs you get from the existing treatment is called the QALY gain for the new treatment. And that is deemed to be the measure of its value. That's how much quality-adjusted life it buys you, the patient. You then divide the extra cost of the new treatment by the quality gain that it gives, and you get the figure that Cliff mentioned before, the cost per quality. So if it's given you 10 quality-adjusted life years, and it cost £10,000, then that is coming in at £1,000 per quality-adjusted life year. That, by the way, would be a real bargain, but it's a simple number to understand. You then compare the cost per quality with some kind of threshold which you have defined, and more about that in a minute, to decide whether or not this treatment you are looking at can be considered to be cost-effective or value for money or affordable or not. And a decision is then made based on that and on other relevant factors like government priorities and the like. So these systems sound very complicated. They are complicated to operate, but conceptually, they're quite simple, actually. It's life, and the quality of life gives you a number. And that's one of their attractives. They're used in countries like Australia, where they were first inaugurated, in Canada and the UK, and they're very popular in a number of countries around the world, including some other countries in Europe, Asia, and elsewhere. They have a number of advantages. They are relatively objective in deciding whether or not a treatment is cost-effective or value for money. And very important for some, they give all patients and diseases the same opportunity to access limited resources. You can calculate QALYs for any disease and any patient group, and they're all comparable. Everyone lives and everyone has a certain quality of life. And so you can compare different treatments and different patient groups with one another. This is very important for countries that operate fixed budget, national healthcare type systems. Because in those systems, when I spend £100,000 on a new cancer patient, I have £100,000 less money to spend on another patient. So I want to have some way of comparing the value that the cancer patient gets directly with the value that some other patient might get that I could spend it on, because I can only spend that money once if my budget is fixed. Okay? So QALYs tend to be quite popular in systems like that. But they're far from perfect, and they have a number of challenges. How, for example, do we set this threshold for what defines whether something is value for money or an appropriate price? NICE, in the UK, uses a threshold of around $30,000 to $50,000 per quality-adjusted life year. Other organisations use different thresholds. Research in the UK has suggested recently that that NICE threshold should be much lower than that. That would cause real problems for new treatments and many patient groups. But it is argued by some that if you look at what you're taking resources away from in the health service, it's a bad deal if you're funding things at this kind of price. So there's a lot of controversy around what this threshold is that is so critical to the decision making. QALYs use generic quality of life measures, so that allows them to compare cancer with haemophilia with mental health. That's great if you want to compare cancer with haemophilia with mental health. But if you just want to compare cancer with cancer, cancer drug A versus cancer drug B, these generic quality of life measures are very blunt instruments. They miss many of the subtleties and the nuances of the patient experience in real diseases. And finally, and in some people's eyes most importantly, QALYs are inherently ageist. If you have a drug that saves life, and it saves the life of children, they are going to live another 70 or 80 years. That's an awful lot of quality-adjusted life years. If you have a drug which is more applicable to old people, and it saves the life of someone like me, who's going to live for another 20 years, that's much less QALYs. So a drug which is equally life-saving at different parts of the lifespan generates different levels of QALY. So QALYs are inherently ageist. And for many people, that is a fundamental problem with them. So what's the alternative? The alternative is the so-called clinical added benefit system. Here, you compare the clinical benefit of a new treatment with the existing treatment, and you very simply place it in one of a number of predefined categories. So you say this drug offers major added benefit compared to the current treatment, or considerable benefit, or minor benefit, or actually it doesn't offer any benefit over and above the new treatment. Note that those categories are actually very carefully defined. So you can't just say, oh, I think that's major because I like this drug. Major is defined as, oh no, by that we mean you actually recover from a disease or cure. There's a significant extension of life, long-term freedom from severe symptoms. So major means major. Okay, it's defined quite tightly to be meaningful. And then you use those categories of major, minor, none to make your judgments or make your negotiations on what the appropriate price for that drug is. So if there's no added clinical benefit over the existing treatment, most systems simply say, absolutely no difference in price. I don't care how expensive your drug was to develop, I'm giving you the existing price because it's no better than what I've got. On the other hand, if you come in with significant or major added benefit, you might get a significant or even a premium price compared with the existing products. So these systems are used fundamentally in Germany. It's probably the largest country using them. France uses something very much like this. They allow all assessments to use disease-specific quality of life measures, so they can be more sensitive to the conditions and the patient experience in the actual disease being looked at. And they provide a degree of consistency and objectivity, but they combine it with some pragmatism and some flexibility and space to negotiate about price and the like. Challenge is, it leaves much of the decision on actual price to judgment and negotiation, because, major clinical benefit could give you any price from a little bit more to 5 times as much. How do you decide what that price should be? And these are less helpful than cost per quality for making trade-offs between different conditions. So they're not very popular in countries that run national health services with single budgets that are fixed that need to try and be fair to all conditions. Well, you say, goodness me, that's all very complicated. Why does everyone bother getting into all this difference and detail, and does it actually make any difference? Well, the answer is yes, it does make a difference. There is quite a lot of evidence to suggest that the way that the HTA is done and the kind of system that is used does affect the outcomes for you, the patient, and for the company seeking to get the drug covered. So the way it works is, in practice, most HTA-based decision systems approve a lot of the new drugs and treatments that are put to them, but almost all reject some or limit access to some on the basis that cost is not justified by the level of benefit offered. So these bodies have teeth. They're not just going through a process and approving everything. They do say no. They spit things out. And interestingly, whilst most of these systems reach similar views on clinical benefit or value, they reach differing views on whether or not the treatment is value for money. Now, this in part reflects the fact that their countries and their systems have different levels of wealth, they may have different priorities, there may be different political pressures. But it also seems to relate to the kind of system they operate. So those countries operating the clinical added benefit system are definitely more likely to approve expensive new drugs offering relatively small benefits for specific conditions, such as cancer. Cancer drugs do much worse under quality-based systems, where the lack of quality-adjusted life years for the price being paid is more apparent. So, Cliff, how does it work in the US?
How it works in the US is messily. Whereas in Europe and other parts of the world that Chris mentioned, there are one or few payers that might mediate access or influence decisions about access. There are many, many, many more in the United States, no two of which look the same. First, I want to say this about HTA in the United States. A lot of things that look like HTA to Chris and me, or HTA related, are not necessarily labeled as HTA. So if you care about HTA in the United States, don't just Google HTA. Yes, it might be called health technology assessment. It might be called things that are related to it, like comparative effectiveness research or PCOR, like patient-centered outcomes research, or PE, pharmacoeconomics, or EBM, evidence-based medicine. Many other organizations are working on things now called value frameworks, and I'll tell you a little bit about those in a few minutes. So the point is that don't just look for the letters HTA, look for what they're doing, how they're doing it, and whom they are advising. By the way, if you're clued into what Chris and I have been saying so far, and you're thinking to yourself, how much does it cost per year to provide care for a hemophilia patient? $100,000, $300,000, $500,000, $750,000? More? It's going to be more for some patients pretty soon with the genetic stuff. And is somebody going to start asking how many qualities they're getting for $500,000 or $750,000? What data are they using? Do they have a threshold? Keep that in mind. Okay, in the United States, HTA-related organizations are these, and I'm not going to talk about all of them, but I kind of want to give you the idea for what's there. In the federal or national government, there is the Agency for Healthcare Research and Quality called AHRQ. It has several programs that are related to HTA. The evidence-based practice centers, they've got a technology assessment program. The U.S. Preventive Services Task Force, USPSTF, does HTA kind of stuff for preventive services like immunizations, like screenings. CMS, the Centers for Medicare and Medicaid Services, has a coverage and analysis group. That's the group for which I headed the National Advisory Panel. By the way, CMS is the world's single largest third-party payer. CMS spends more money on health care than any other country in the world. The Centers for Disease Control and Prevention, CDC, does things on, as it says, disease control and prevention, also injury prevention and so forth. They've got some programs that look like HTA. In the state governments, the 50 states plus District of Columbia and others, at the state level, there's something called DERP, the Drug Effectiveness Review Project. They say they do assessments used by quite a number of states in the United States, the state Medicaid programs that provide health care for poorer people. There's MED. A couple states, Oregon and Washington, have their own designated HTA programs. So that's just on the government side. Now, in the private sector, of course, many payers, and whether it's Blue Cross Blue Shield or Kaiser Permanente or commercial insurers like United Healthcare, Anthem, Aetna, Cigna, Humana, they all do stuff that looks like HTA. It's almost never called HTA. They either do it internally and or they use stuff from outside vendors for HTA. Try it yourself. Go to, get on the internet, look up, Aetna medical policies, and they have very detailed descriptions of the basis for making coverage decisions. It's really detailed. It cites other HTA groups. It does systematic literature reviews. It looks just like HTA to us. PBMs. Oh, don't forget about PBMs. Pharmacy benefit managers. Increasingly in the United States, large insurers carve out, that is, they assign the management of health insurance for drugs to PBMs. PBMs are few and powerful in the United States. Believe me, they use HTA, including some of the other groups I'm going to show you in a minute. They are increasingly at the nexus of decision making, often negotiating with pharma bio companies on prices and representing other groups, employers and other payers, key players. There are also a variety of independent assessment organizations, ECRI, HAYS, CMTP. ICER, Institute for Clinical and Economic Review, has special prominence today, these days, because ICER, as a nonprofit HTA group, had very much to say about and a lot of influence on what happened with the very expensive new drugs for hepatitis C. You may recall that those drugs cost $1,000 a pill. You took them for 12 weeks and actually cured more than 98% of people with hepatitis C. That sounds like a pretty expensive drug, and ICER had a lot to do with some later negotiations by PBMs and others that changed the price of those. They did a detailed HTA. It was quite influential. The U.S. Cochrane Center, Cochrane Collaboration is an international network that does systematic reviews that are used for HTAs, and a variety of consulting firms, market research firms, and academic centers do HTA. So there's a lot of stuff going on in HTA in the United States. It's not always the same thing, and they advise many, many payers. Okay, by the way, what's going on in the United States now that catches special attention is the work on frameworks for assessing value. We talked about value for money, and now there are frameworks that say a priori the approach you're going to take to assess value or value for money. You can see it, a couple of them, American Society of Clinical Oncology and the Memorial Sloan Kettering Drug Abacus and the National Comprehensive Cancer Network are largely devoted to cancer, and they look at value and value for money. American College of Cardiology Heart Association, they do primarily cardiovascular work. Institute for Clinical and Economic Review, ICER, does across the board. They do pharma, bio, devices, procedures across disease areas, and others. So I want to show you a couple examples. First of all, American College of Cardiology. Rarely in the United States does anybody talk about quality-adjusted life thresholds. They do, and they just started doing this, I think less than 2 years ago. Look what they do. Does it look familiar to you? What's a high-value technology? Well, better outcomes at a lower cost or an incremental cost-effectiveness ratio under $50,000. If you come in with a new technology, it's less than $50,000 to buy a quality, that looks pretty good to them. They like that. If the value comes in between $50,000 and $150,000 per quality, you're saying, well, that's okay. We're a little more skeptical about it, but maybe we'll let you go on that. A low-value one is really something where you've got to spend a lot more money, like $150,000 or more, to get that one more quality. I was really taken aback myself. I was not ready for a group that's more traditional like this in the U.S. to start talking cost per quality adjusted life here. And then there's an uncertain value category and so forth. So this is something that caught my interest and shows that the traditional part of organized medicine is recognizing value for money and is willing to talk about thresholds. Now here's a value framework that does not do the calculation. They're not doing incremental cost-effectiveness ratio here in cancer, but what this group does at the left-hand side is they look at 2 cancer drugs for a given indication, and they say which one, what's the reduction in risk of death one compared to the other. In this one, there was a large reduction of risk of death. Toxicity were pretty close, comparable. One's 27.5, one's 20.5. Then they looked at something called NHB, which is net health benefit, which is kind of what's the trade-off between clinical benefit and toxicity. And on the far right side, they listed the cost, and this is just the cost of the medication and supportive medications for the 2 drugs. Kind of interesting, right? One's almost $36,000, one's $3,000. The purpose of this is to help doctors and patients try to figure out what to do when they've got choices to make for oncology care. So that's one kind of value framework. Here's another. This is used by ICER. I'm not going to explain this in detail, only to tell you that what ICER does, they do both cost-effectiveness analysis and budget impact analysis. They not only ask, hey, did that new drug for hepatitis C, is that cost-effective every time a patient uses it? Yes, no. And by the way, even if it is cost-effective for every individual patient, can anybody afford that drug for all the people who could benefit from it? ICER does both of those, so value frameworks. Okay, we'll talk next about how HTA is being used in decisions on high-cost treatments and treatments for rare conditions. Chris.
And this is the last section in our preparation, as it were, for a discussion about how all this relates to hemophilia. So we're going to look at the special conditions that are applying to very high-cost treatments and rare diseases. The 2 things sometimes come together, not always. So what is a high-cost treatment? Well, treatment may be considered high-cost because the cost of treating an individual patient is very high, hundreds of thousands of dollars, maybe even millions of dollars, or the cost at an individual level may not be so huge, but there's a lot of them, and so the cost of treating a population becomes very high. Let's look first at the high-cost individual treatments. HTA is kind of relatively clear here. So if a health technology assessment determines that a very high-cost treatment is sort of not too far away from being cost-effective or value for money, so it's very high cost, but it actually produces a lot of benefit, then the systems may look for ways to get a cost-effective outcome. So it will, for example, explore discounting with the manufacturer. Can we bring the price down? Can we get it closer to what we would consider to be cost-effective? It may look at restricting the use of the drug or the technology to the patients most able to benefit, so that way you're going to get the highest cost-effectiveness. Or it may agree to fund it, provided that reimbursement is linked to the actual outcomes achieved. So if we get really good outcomes that would mean it was cost-effective, you get your money, we pay the manufacturer, but we make a deal with the manufacturer that if the outcome is less good than that, we don't pay, or we pay a reduced price. So just in passing, it's worth pointing out that it's easy to think of HTA as the bad guys, but actually HTAs are the good guys. They're trying to make sure we use our healthcare expenditure in the fairest way we can. They may not get it right, you may disagree with them, but they are trying to help. And the way that they deal with high-cost treatments is, to some extent, an example of that. You know, they don't, if they can find a way of finding an accommodation to mean that the treatment can get into clinical care and into patients' lives, then many of these agencies will work to find solutions of that kind. If the cost of an individual patient's treatment is just way above what we would consider to be cost-effective, then most HTA bodies advise the payer just like, sorry, this is just too far. It's unaffordable to our system. And a lot of payers at that point will simply say, we're not covering this. Or in systems where you have co-payments, the way they often do that is they set a co-payment that's so high, it's deliberately designed to stop people wanting the drug. It's a similar effect, basically. You choke demand for it. There is, however, one exception to that rule, and Cliff's going to talk about that in one slide from now, which is very rare diseases, where HTA bodies and payers have reached different conclusions on treatments that are hugely expensive. Just a few words, because it's relevant to our debate, about what about these treatments that there are treatments increasingly facing us that are value for money at the individual patient level. So they're quite expensive, but they really are good. And the hepatitis C drugs are the classic example. They're really good. Their price is, as it were, justified, in inverted commas, by the value they offer. But taken together across the number of people they are applicable to, the budget impact is staggering and in many countries simply unaffordable. What do we do there? What are payers and what are HTA people doing in these situations? Well, actually, some quite similar things to what they've been used to doing in the situations where the drug wasn't quite value for money, but it wasn't far away. So they seek to restrict access to the most severely affected patients. They seek discounts from manufacturers. In the case of the hepatitis C drugs, pretty aggressive discount seeking. And in the case of hepatitis C, there's been some very interesting discussions of much more radical approaches, which may be relevant to some of the issues facing us with hugely expensive gene therapies and the like. So, for example, do we need to find alternative ways of financing treatments in healthcare? At the moment, we pay for drugs up front. If the benefit is spread over a number of years and the cost is enormous, should we be looking at some ways of amortizing that payment so that it's spread out in a way that is more manageable for the healthcare system? Some people have actually been challenging the basis on which drugs are priced and saying we need a system that produces fairer, in inverted commas, prices, whatever that means. And in some countries with a particularly low wealth, in developing countries, they've even challenged the patent protection system and said, well, if that's what it's going to cost us, I'm afraid we're just going to go and make our own and we'll see you in court. That's the range of responses that these kinds of things are triggering. And I think what the debate is showing us is that there's a debate about how we're going to cope with an increasing number of very high-cost new treatments within our current models and our current budgets. So that's where we are. Cliff's going to say a few words about rare diseases, and then we're into the discussion.
All right. Let's think a little bit more about rare diseases and your favorite or the rare disease or one that's most familiar to you. What are the main challenges of HTA involving technologies for rare diseases? Let's think about this. Well, for one thing, when diseases are rare, by definition, not a whole lot of people have them, which makes it difficult to enroll enough patients into clinical trials, especially randomized clinical trials, to yield statistically significant findings, which are the kinds of things that are persuasive and constitute highly rigorous evidence. Don't have a lot of people, hard to find people to put in trials, the trial results may not be significant. So that may undermine or weaken the evidence base with which you're trying to make a case. Next, also, given the severity of many of these diseases, clinicians and patients want to rely on shorter-term or interim or surrogate outcomes rather than long-term endpoints or mortality and morbidity. You know, with very common diseases, we like to wait around long enough to see What are the long-term effects on morbidity? What are the effects on survival or mortality? Well, given how severe some of these diseases are, we don't want to wait around that long. And we don't want to wait till people die. We'd like to see if there's anything else that might indicate that things are getting better, like maybe my cancer doesn't go away, but the tumor is stabilized or shrinking in my rare cancer. Or maybe there's something circulating in the blood that tells me something's working. But traditional HTA says, no, we want the longer-term endpoints. So the evidence base looks weak when these instances arise. Also, traditionally, HTA agencies and organizations have used methods and criteria that are more suited to assessing technologies used in large populations. It isn't just the evidence, it's other aspects of statistics, of expectations of thresholds, and so forth. So they're kind of geared to the bigger populations. For example, the evidence quality criteria and cost per quality thresholds. Evidence quality criteria, as I mentioned, we want rigorous evidence based on large randomized controlled trials and long-term endpoints and so forth. They're not geared to do that. Cost per quality thresholds. Okay, cost per quality thresholds work pretty well. You got a lot of people, and you have an intervention that you can spread out over a population, and you can detect some significant differences. And because you can spread an intervention across a lot of people, and the cost of developing that new drug or other intervention might have been great, but the company selling it stands to cover its expenses because the population, the market is so big, that's okay. But for rare diseases, it costs maybe the same amount of money to develop a drug for rare disease as for a great big disease. And they end up charging a lot of money per patient, which means you may exceed your cost per quality threshold. If someone's spending $750,000 per patient for hemophilia and they do the calculation, divide that by number of qualities, they're going to say, oh, wait a minute, it might not be worth it here. You need to consider that. Furthermore, challenges are these. Prices of new therapies for rare diseases tend to be high or really high, like over $1 million, as manufacturers seek to cover the cost of their development, which I just said may be comparable to the cost of developing a drug that's more commonly used, and to achieve acceptable return on their investment across a much smaller patient population. So prices are going to be higher for new products for rare diseases. So it's more difficult to generate acceptable thresholds for cost effectiveness, as I just said. How are we going to get this thing down to $150,000 per quality or $100,000 per quality, or is that even practical? Also, until recent years, and this is quite relevant to you in the hemophilia area, many therapies for rare diseases, as we say, flew under the radar of payers in HTA. Why? Well, on a per-patient basis, yeah, it was pretty expensive. But you know what? Now that we're getting more people diagnosed around the world, and people are living longer, and more people are covered, the aggregate cost starts showing up on balance sheets. If they're just a few patients, even if they're expensive on a one or two basis, that doesn't look like a lot on the balance sheet. But when there are more people that are detected, more people are treated, and they live longer, now the cost is starting to look more significant. So even at a relatively high cost per patient, the overall budget impact was small due to a few patients. Now it's changed. And finally, here's an irony. The very success of therapies for some orphan diseases has increased their budget impact substantially. How long did people live in the 1960s or before when they got hemophilia, when they were born with hemophilia? How long did they live? Well, since then, for the most part, except for a very bad set of errors and epidemiologic problems in the 80s, since then, people live longer. Every year they live, they use more factor. Every time more factor they use, the more expensive they become to the system. And as they get older, living longer and so forth, guess what else happens? We get diabetes and heart disease, obviously more joint replacements, cancer, other diseases. So these patients that used to die young now are expensive to treat on an annual basis, live longer, and get sick from additional things. All of a sudden, these are pretty expensive people. Also, national policies to encourage drug development for rare conditions are actually working, leading to more therapies. So what do I mean by that? Well, When you think about this, such as the Orphan Drug Act in the United States and a similar act in other parts around the world, we've actually been providing incentives to encourage companies to develop drugs for rare diseases. That's good, and that's been successful. Many more new products are developed for rare diseases. But guess what? That means there's a lot of competition among groups representing their respective rare diseases. So if you're trying to make a case to a parliament or Congress or policymaker, you're kind of competing with other people in rare diseases trying to make similar case, and all of these diseases have expensive therapies. Good news, patient advocacy is increasing and is more sophisticated across more rare conditions. Patient advocates are less often brought in to say, gosh, isn't it so awful this person has this terrible disease? And more often we're saying, well, guess we have people, we've got people like Mark Skinner and other folks that are very active in the advocacy community that get all this stuff. They get clinical trials, they get primary and secondary endpoints, they get reimbursement policy, they can make a strong case and know where to make it. So that, I think, is a good point or aspect of rare diseases. Still in all, there's increased competition for the attention of payers in HTA. More challenges, and to the extent that we're all getting better at this, it means you're competing with others for the same pots of money. Briefly, some good news. National Institute for Health and Care Excellence, NICE in the UK, and others that do HTA or support HTA, they're starting to bend their own rules and become more flexible. They came up in this case with a highly specialized technologies program to alter somewhat the way they're doing their assessments. I won't go into great detail, but they recognize that in situations where there are very small numbers of patients living with these rare conditions, not to use the same utilitarian approach, so they're changing that. They're also looking at, when they evaluate costs, is there a different way we can look at the costs of these products, maybe to perhaps even account for the reasonable cost of developing these things, okay? So they're kind of bending some older rules based on that. And they're also looking at weak evidence, as I described before, how the evidence can come in weaker, less rigorous. How can they adapt to that and provide some, as we say, wiggle room or flexibility? That's all to the good. And what you may want to think about doing when you deal with HTA organizations in your countries is, are they hewing to the old strict rules, or are they showing flexibility for rare conditions? Here's a very good example of how they applied some of these new situations. They had a new guidance for so-called ultra-orphan diseases. This happens to be a blood disease. And I won't go into detail about this, but in early 2015 was the first time they actually said this is okay under the new sets of rules for highly specialized technologies. They did give special requirements about how to provide the drug to certain patients under certain conditions. They had a protocol for deciding, hey, is it time to start this thing? Is it time to stop it? So there were some rules around it, but they allowed it under a set of conditions that they would not have done previous before that. And as this chief of the NICE said at the bottom, this committee accepted that this drug is a step change, not a minor incremental change, a step change in the management of this disease, and can be considered a significant innovation, meeting a high unmet clinical need. Somebody came up with a drug that met this unmet need. They're willing to pay the price under certain conditions. Chris.
Thanks. We're there. By the way, that was the most expensive bottle you've probably ever seen on the last slide, just in case you didn't realize. Okay, we're going to offer some thoughts which we can review after the discussion and see whether you agree with them. What does this mean for patients, and what can patients do? Well, okay, take-home messages. Health systems around the world are increasingly considering value and basing decisions on it. They're increasingly cognizant of rare and expensive treatments. You're no longer flying under that radar. Patients and the public at the same time are increasingly asking, how is all this stuff defined? What is health technology assessment? Who defines value? How are assessments and decisions being made? How are prices being set by manufacturers? So there's a healthy climate of debate developing, which is important for patients to think how they're going to join, I think. So what things can patients do? Well, we would encourage you all to think about, learn about HTA. Don't see it as some mysterious thing practiced by high priests in secret. You need to find out about it because it's affecting your access to things. So find out what it's doing, find out what its assumptions are. So if you don't agree with them, you can challenge them and its values and its benefits. Apply to join HTA committees and advisory groups. Many of these organizations invite applications from patient groups and lay people. Make your views known on the basic approaches and the methods being used for assessments and decisions. If you don't think the approach is fair, say so and say why. Say how you think it could be done better. Submit evidence to specific assessments. If they're looking at a drug that affects you, give your evidence to that process. Most of these bodies and systems have ways of receiving the evidence. And when appropriate, when you've done all those things and you still think the answer is wrong, challenge it, question it. That is your democratic right in most of these systems. And people are increasingly exercising that right, and that is your right to do that. So I think the key point is get engaged, get interested, because this is here to stay and it's going to get more important. So hopefully that's set the stage for HTA in general. We could have given this talk up to now at any kind of patient group meeting or any disease meeting. The question now is, how does it apply to your particular condition and the drugs that are coming up in the next few years?